All right, guys, good evening. I hope everyone has been having a good week. It is freezing in Ohio. It's like 7 degrees. So sad. That sucks. But we're gonna get started on this second quiz here pretty quickly. So just to reiterate something, I know last week I kind of gave you guys the wrong information. We do need to have two separate devices for quizzes as well as exams. So typically, what people do is they'll have their phone with the Zoom, and then they'll have their laptop or tablet or other device to take the quiz on. Okay, so we'll need to have two devices for both the quizzes and the exams moving forward. So if anyone needs to go and grab another device really quick, I'll give you a couple minutes to do that. But if everybody is ready, we'll just go ahead and get started on the quiz. Does anybody need to go and get a different device, or are we all set? Okay.
Hold on.
All right, we'll give a couple people a little bit of time here. And then, Mercy, if you could break, please.
I wasn't able to understand what you said.
Oh, you do have a screen already. Never mind. You just have two different things in here. That happened. I keep doing that. You're fine. And then who?
Sorry, do we, so we're not logging in on two devices, you're logging in on one.
Yes, you're only logging in on one device. You don't need to have both devices logged in, but you need to have one device that's strictly for Zoom, and then your other device is going to be what you're testing on.
Okay, hold on, let me do that.
And then Cassandra, I'll need you to turn your camera on, please. And then Anais, I'll need your camera on as well. Thank you. Okay. And then Joanna, is your other screen the Samsung one? Whoever has the screen that has like the Samsung SM.
I'm trying to change it.
Oh, okay, no worries. You honestly, if you're on one device, as long as you have a separate device to test, you don't need to be logged in on two screens.
Okay. So I'm gonna log out my phone.
Okay.
I'm sorry, my internet is so slow. I want to um switch to viewing it on my phone so I can take it on the computer.
Okay. So everyone should have a second device that they're testing on. I see everybody now is in screen. So once Cassandra comes back, I'll give you the access code and we'll go ahead and get started, okay? So the same thing applies. You're going to have 15 minutes to take the quiz. It's a 10 question quiz. When you're done, you can just shut your screen off, but don't go anywhere because right after everybody's finished with the quiz, we're going to get started in class. We have a lot to cover today, okay? So if everybody's ready, the access code for your quiz is fetus with a capital F. All right, if everyone wants to come back on screen, I think we're all finished. So we'll get class started. Okay, so the first thing that we have a couple of things that we need to talk about and cover before we jump into our class PowerPoint. So I don't know if you guys were looking through your submissions, but I went through last night and changed your guys' grades for quiz one. So there was an issue with one of the questions, the select all that apply question. A student had said that they found it in a study guide, and on the study guide there was only one correct answer rather than it being a select all that apply, which the answer for the select all that apply for that quiz was all of them. All of them were correct. So instead of just like trying to like figure out how to divvy up points, we went ahead and gave everybody a point back for that question. So if you saw your grade change, that's why. I put a little comment in there for the quiz for your reference. But that's nice to have a point back. You know, that's never a bad thing. So, and if we typically don't do that for quizzes. Usually our quizzes, we have almost all the professors review them and whatever. So, this question we just thought felt it would be more fair to give it back to you guys for a point. So if you see your grade change, that's why. So let's go ahead quick. I'm going to pull up Canvas. We're going to go over what we have due this week. And then I want to go into our announcements because there's some important stuff that I want you guys to know for exam one. Okay. Let me move this out of here. Okay. So for this week, you guys have a couple of things that are due that I want you guys to definitely make sure you're turning in on time. So we go to module 3 here. We just took our quiz. That's done. You guys have your sim chart infection that will be due on Sunday. And you also have your first NCLEX question assignment that will be due by Sunday night as well. Okay. Last week I kind of went through it a little bit more in detail, but if you click into this assignment, It has everything outlined for you and what you have to have completed and how to complete it. The most important thing is selecting whenever you go into the NCLEX dialog box. Follow these directions pretty carefully as far as like what questions you're selecting to answer, because that's what we're going to be grading. I've had students in the past who just go into NCLEX and select new questions only and then just get going. And they're answering questions in like med surg and stuff. And for this class, that's not really pertinent. I'm glad you're getting the extra practice for your med surg class, but we want you to answer the questions under the maternity content. Okay. So follow these instructions step by step whenever you're going to do them. The other thing we really need is I need this proper name, like this file name here. So you see how it says NUR 202 underscore week 3 underscore NCLEX, and then your first initial last name and the date. Okay, I need that to be at the top of the page. Otherwise, I'm going to ask you to resubmit it. Okay, this being the first assignment, if you submit it incorrectly, I'm not going to give you a 0. I'm not going to take points off for a late penalty. I'm going to send you a message in Canvas and ask you to redo it and submit it as soon as possible. Okay. But please just try and follow these instructions because it's pretty easy once you're just looking at this and you're following it this way. Does anyone have questions over the NCLEX assignment or SimChart? Everyone seemed to do pretty well on SimChart this last week. So typically if we're running into issues, it's that first assignment. So just keep me posted if you need anything else. All right, that brings me to our announcements, and there's some things that I want you guys to definitely go into. Let me click this as a view as student so you guys can see from your side of things. Okay. So you guys got a lot of messages about ExamSoft and about the study session and all that stuff. The most important announcement that is in your Canvas at this time is this Exam 1 study session, study material, and recordings. So when you go into this announcement, this has listed all of the different review sessions, what time they're at, who the, I almost said provider, who the professor is that's hosting the review session, and their Zoom ID, and if there's a passcode required, they give you the passcode here. Okay, you can go to all of these. You can go to one of them. You don't have to attend them. They are completely optional. They are a resource for you whenever you're preparing for your exam. Personally, I would recommend you guys attend at least one. I think they're definitely worth your time. Something that's important to note is that every professor runs their review session a little bit differently, okay? So in my review sessions in the past, I've played Kahoot review games. I've done some like Jeopardy review games. Most of the time, I'm just running us through practice problems. Some of the other professors have like little study guides that they go through with students. Other professors have little mini PowerPoints that they run through, like almost a mini lecture. So kind of mess around with it, see what works best for your schedule and which professor you prefer to review with. It does not have to be me. You are not going to hurt my feelings. I want you guys to do what is best for you and what fits the best with your schedule. The other important thing that I want you guys to see in this announcement, right here, this Exam 1 blueprint, that basically outlines the concepts that are going to be focused on in the exam. Okay, this comes usually from ExamSoft. So if you are having difficulty narrowing down, what do I study? There's so much material, there's so much content, which there is. This class has a lot of content. This Exam 1 blueprint is a really good place for you to start if you are interested in building your own study guide, or you just need something to pinpoint you on, yep, this is where you need to focus. Here's where you should spend your time. Okay. So this announcement is really awesome, and it's going to be very helpful for you, especially for the recordings. The other thing I wanted to mention too about this is where all of these are listed. So I don't have it updated yet because I haven't received her recording from this morning. I'm going to be putting the recordings from each professor's review session in this announcement so that you guys will be able to watch them on your own time if you would like to. Okay, so you will have access to every professor's recording. You'll be able to go in and watch the review session, even if you weren't able to make it. We do it that way because sometimes with schedules and work and classes and personal life, it's hard to get to a review session. So we include all the recordings in here so that you guys can use them as you need them. Okay. I try to update them at the end of the day, whenever there's been like a couple of them, right? So like there's one tonight at 8:15 with Professor Alani. So I mean, you guys could go right from my class tonight to her Zoom to do a review session. That's a lot of class time, but you know, if that works, if that's what works for best for your schedule, please do that. So I probably won't update this um, announcement until late tonight when she's finished, or tomorrow, sometime tomorrow. But I will get to it, I promise. Okay. Going back into our announcements, I have had a couple people ask about the practice exam, downloading it, downloading ExamSoft, how that works. So this little announcement here says the ExamSoft practice exam is now available. Here is your password, Fortis01, all one word. You must take time to do the practice exam before next weekend on the device that you use for testing. This is super important, okay? I talked about this probably in the orientation week. When you download ExamSoft, it has to be on the device that you're going to test with. Otherwise, the day of the test comes, if you have not downloaded it onto that specific device, you're not going to be able to get in and you'll be locked out of the exam. Okay. This helps ensure you have completed the software update, especially if you're testing on a different computer than you've used. Okay. If you need assistance registering for ExamSoft, please follow the link in the student resources in the modules titled How to Register for ExamSoft. Okay, so if you're running into issues technology-wise or just in general, like you've downloaded the exam or whatever it may be, and you have questions, please go to that student resources link in our modules so that it can give you like better information. Okay. If it gets to be like Tuesday of next week, Tuesday night of next week, and you're reaching out to me in a panic, like, Professor, I can't download this. I don't know what's happening with my ExamSoft. I'll still try and help you if I can or if I see your announcement, but just remember that I teach another class before this. So I'm in class on Wednesdays from like 2 p.m. until our class finishes. So I might not be able to help you right away, and I don't want you to get in that position. So please try and download your ExamSoft ideally before this weekend if you can. Okay. Let's go back to our announcements quick. Okay. On Tuesday night, I'm going to be sending out an announcement that'll say something like preparing for test day or something. I forget how I titled it last term. That announcement is going to have listed every single thing that you need to know before you take your exam. Okay, so please read that through very thoroughly because we've had a couple of issues getting started with our quizzes this term, which is fine. It's to be expected. You know, stuff happens. But with the exam, because I have to check all of you guys in individually, it takes a while for us to get started. And I want you guys just to be able to get going on your exam so that we don't have to wait around for that. Okay. So please read that announcement when it comes through. Look for that on Tuesday. The big important things that I want you to know is we need to have the two devices again. So the one device that you're going to be Zooming on and the other device for your test. You have to be preferably in a quiet area. Before the exam starts, I'm going to go through everybody and ask to see your Fortis ID or an ID that just has your picture, your first and last name on it. And then I'm going to have you show me a 360 view of the room that you're testing in, including the surface that you're testing on to make sure that you don't have any notes out or textbooks, whatever. And then underneath your computer as well. If you choose to use a whiteboard, which everybody is able to do, a whiteboard or any type of dry erase board, I will just have to see that before the exam starts, and I'll have to see it at the end of the exam to make sure you've erased everything. Okay. If I check you in and you're all set to go, you don't have any notes out, everything is good, and you want to write notes on your whiteboard like immediately before I officially give you the passcode for the exam, I am okay with that, but just know that you cannot get your notes out after I've already checked you in for the exam. Okay. It'll be myself and another professor in the Zoom with us proctoring the exam. So we'll all be like keeping an eye out to make sure that nobody's like trying to cheat or do anything crazy. Okay? Any questions about any of that? Sweet. All right. So like I said, this week we have quite a lot to cover. I don't know if you guys were reviewing the classroom PowerPoint before today or not, but it's pretty extensive. So my last class we didn't get to all of the information. If that happens, what I most likely will do is write out like a Word document and send you guys the rest of the PowerPoint answers so that you can compare it to the notes that you've been taking or anything that you've used for your own purposes. But that probably won't get out to you guys until maybe like Friday because I'm working tomorrow in the OR, so I'm going to be at work for a 12-hour shift. So it might not get out to you until the end of the week. Okay, but we'll try and cover as much as we can. I'm still planning on not taking a break and getting out 10 minutes early if you guys are okay with that. Sweet. Um, I think that worked well last time, but like I said, I might have to take a pee break, so just bear with me. Okay. All right, but let's go ahead and get started in this. All right, let's start with some review from last week. Okay, how does the placenta provide oxygen and nutrients and remove waste for the growing fetus?
Isn't it the hemoglobin carries the oxygen?
Our hemoglobin does carry oxygen, yes. What is a big component of the placental anatomy that helps with transfer of, maternal fetal blood, all that stuff?
The umbilical cord?
Our umbilical cord, yeah. So, our placenta diffuses between maternal vessels and fetal vessels in the placenta. The umbilical cord is attached between the placenta and fetus to bring in oxygenated blood through the umbilical vein and remove waste through the umbilical arteries. And like we kind of talked about last week in class, it relies on maternal blood pressure for perfusion, right? So we kind of briefly talked about um, how mom's blood pressure will affect our placental perfusion. So what's going to happen if mom has really uncontrolled high blood pressure? Is that placenta going to be perfused well if our mom's blood pressure is really high? No, it's not. So, right, we have to think about it from an entire anatomy standpoint. So, mom's blood pressure is elevated, her vessels are constricted, her body is working really hard to maintain her cardiac output. She now also has 40 to 50% more blood volume during her pregnancy, right? So her body is working really hard just to sustain her blood pressure, which is now elevated. So those vessels that are constricted, is the placenta at that time the priority for mom's body? No. So mom's body is way more concerned with perfusing its own vital organs. At that time, the placenta is not considered a vital organ. So that placenta is not going to be getting the correct amount of blood flow. We're not perfusing very well. No, decreased amount of perfusion and decreased blood flow through the to the placenta means decreased blood flow and decreased oxygenation to the baby. So it's all connected. Whatever is happening to mom is ultimately going to affect the baby. Okay. This second point here, how the umbilical cord is attached between the placenta and fetus to bring in oxygenated blood through the umbilical vein and remove waste through the umbilical arteries. I would definitely know where your oxygenated and where your deoxygenated blood flows through, right? So in my recorded lecture, I talked extensively about the circulation between mom, baby, placenta, umbilical cord, umbilical veins and arteries, all that good stuff. So I would definitely know that blood flow for your exam for sure. All right, what are some danger signs that we should educate our pregnant client to report to her primary care provider or to her OB, I should say?
Lack of fetal movement.
Yes.
Any blood?
Any bleeding, definitely. What are some other ones?
Leakage.
Yeah, if she's having some fluid leaking, definitely. You guys hit a lot of them. Let's see. So our absence or of changes in fetal movement. So we talked about this pretty extensively last week. So what do we tell moms? How do we monitor fetal movement? What would we educate mom on how do we do fetal kick counts?
It was like 10 kick counts within an hour. And if you don't feel within an hour, then lay on your side and count for the next hour.
Yep, definitely. Yep. So you should have at least 10 fetal movements within 1 to 2 hours. And just like you said, if she's not feeling movement within that first hour, lay on your side, drink some water. Um, should we be telling mom to do these at different times of the day or at the same time every day?
The same time every day.
The same time every day. Yep. The other thing that I want to talk about though is so we briefly mentioned this as well, I think. If your mom has fetal movement, but it's different than the fetal movement she typically feels, would that still be a sign of concern? Yeah. So if mom has a super active baby, this baby's kicking her 24/7 all the time, moving around like crazy. Um, who knows why? This baby's just super active. And then she calls into the unit and she's like, usually my baby kicks me all the time and she's still moving, but it's been a little bit less than what it normally is. We would still give her that education of, okay, lay on your left side, drink a big thing of water, and if it's still a little bit decreased, then you need to come in and be evaluated. Okay, and that's when we're going to get our non-stress test to check and make sure baby is reactive. Potentially get a BPP or an ultrasound as well. Okay, for our blurry vision, our headache unrelieved by Tylenol, right upper quadrant or epigastric pain, and then our heartburn accompanied by a headache. What do we immediately think is going on with this mom if we see these signs and symptoms?
Preeclampsia?
Preeclampsia, yes. And is this an OB emergency? Yep. So, preeclampsia, whenever you guys see right upper quadrant or epigastric pain, I want you immediately to think preeclampsia. Okay. Those are pretty telltale signs of a preeclamptic patient. And that would be an emergency, and she would need to come into the hospital. Any bleeding at all during any of the trimesters is a reason for concern, okay? In our first trimester with bleeding, we're worried about miscarrying. We're also worried about an ectopic pregnancy, potentially, that implantation occurred outside of the uterus and that endometrial lining. In the first trimester, we could also be concerned for like a ruptured cyst or something like that too. There's a lot of things in the first trimester that can cause bleeding, but we still want to take it seriously. In our second and third trimester, what are some things that can cause vaginal bleeding? And not all of them are necessarily emergent.
Like micro tears.
Yeah, so like our cervix is extremely vascular during pregnancy, so sometimes moms may have like miniature like little vessels on the cervix that rupture or have like little tears that can happen. Yeah. What's one that's like an emergency like that we would definitely need to know right away? And this is kind of getting ahead of ourselves. I'm just trying to tie it all together. A placenta previa can cause bleeding, especially in the second and third trimester. A placenta previa is what happens when that placenta embeds and implants and grows over the cervical opening. Okay. This is dangerous because obviously, if mom starts to labor, that placenta is going to be the first thing to let go and deliver before the baby. And we don't want that because that's baby's oxygen source, right? Without a placenta, we do not have a reassuring, alive baby. So, placenta previa would be a cause for concern with bleeding. Another thing in any stage of pregnancy would be if mom has sexual intercourse, that can cause some light spotting or some bleeding, okay? We usually give them education about this and just tell them, like, hey, after, if you have some spotting, that's fine. If you're filling a pad within an hour, we need you to come into the hospital, okay? Occasionally, bleeding can indicate that mom is having cervical change. Could indicate potentially that mom is going into labor. This would especially be concerning if she was early or preterm. Okay. So, anyways, anytime mom has bleeding, we need to know about it. Leaking fluid, contractions, or pelvic pressure prior to 37 weeks. What do we think is happening here? If a mom calls in with these symptoms, what do we think is going on?
Going into labor early?
Yeah, preterm labor. Yep. So these are the things that OBs typically will educate their patient on, that if you're earlier than 37 weeks and you start to feel that pelvic pressure that doesn't let up with rest and fluid, you're leaking fluid, you're having regular contractions, you need to come into the hospital because they need to rule out preterm labor. Flank pain and painful urination can sometimes also be signs of labor, especially preterm. That flank pain is more common, but that's also signs and symptoms of a UTI, which we need to have our patients be aware of because urinary tract infections themselves can also sometimes start contractions and put moms into labor early. When do we start measuring our fundal height? How do we do it, and what measurement is anticipated? So somebody walk me through how we're doing fundal height measurements.
So you start at the top of the pubic bone and then go up to the highest point around the umbilicus.
Yeah, you go to the top of the fundus. Yep. So you go to the mom's fundus. So yep, you go from pubic bone to the top of mom's fundus. When do we really start doing fundal measurements? Do you guys remember?
I think
20
it's
weeks.
Sorry, what was that?
20 weeks, no?
Yeah, 20 weeks. Yeah. Usually we start doing them around 20 weeks. And that's only because before 20 weeks, the fundus is usually not super prominent, right? And we want to start measuring whenever the fundus is at the umbilicus, which is usually around 20 weeks. So around 20 weeks when the fundus is at the belly button line, you measure from pubic bone to fundus, and your centimeters should equal gestational weeks plus or minus 2 centimeters. So I'm currently 24 weeks pregnant. So whenever I would go to the OB, they should measure me and I should measure about 24 centimeters. Okay, it should line up with your gestational age, which is pretty easy to remember. What are the 3 signs of pregnancy and what are 3 examples of each?
Miss period.
Which would be what kind of a sign?
And
Probable?
I believe amenorrhea is a presumptive sign. So what are the other 2? So we talked about presumptive sign. What were the other ones?
Probable?
Yep.
And then positive signs.
Yes. So think about presumptive. It has the S in it. So that's subjective. So that could be what mom says is she's experiencing, right? So what other things would fall under that category?
Nausea, vomiting,
vomiting.
Yep.
breast tenderness.
Yes, definitely. So those are all things that mom could experience or feel that could indicate to her like, oh, I might be pregnant. But they are not necessarily linked only to pregnancy. What is the other one? So with probable, what kind of things are we talking about there?
A positive HCG urine test?
Yes. Yeah, definitely. So our HCG, which typically whenever we have a positive pregnancy test, everyone is like, yeah, I'm pregnant, right? But that's not definitively, yes, you're pregnant until our positive signs, right? Which are what?
Heartbeat, ultrasound.
Yep. Whenever we actually see or listen or hear the baby. So here we go. We got our presumptive signs, which is amenorrhea, breast changes, nausea, vomiting, fatigue, frequent urination, quickening, pigment changes. Okay, things that mom can experience. Probable would be your pregnancy test, your Chadwick's, Braxton Hicks contraction, Hagar sign, Goodall's, and McDonald sign. Your only positive signs would be coming from the fetus. So we listen to fetal heart tones, we see the baby on an ultrasound, or provider can actively feel the baby's fetal movement. Okay. Definitely for your exam, know the difference between Chadwick, Hagar's, and all those signs. Okay. What are 3 changes that happen in the body during pregnancy?
I guess hormonal changes.
Hormone.
Like weight gain?
What was that? Sorry.
Are you meaning like weight gain?
That could be, yeah, really anything that's happening during the body during pregnancy. So yeah, weight gain's one. I think someone said hormone changes. What are the 2 big hormones that are involved in pregnancy that fluctuate?
Estrogen and progesterone.
Yep, estrogen, progesterone. What about our cardiovascular system for pregnancy? That's going to change a lot, right? So we're going to have skin changes, right? We're going to have that dark line that can sometimes extend midline across the belly. Same with the chloasma and then the darkening areolas. Sometimes moms will also experience a relaxed pelvic joints, that lordosis or that curvature of her lower spine because the body is altering the makeup to make room for that baby and how the organs are shifting. Moms will also complain of carpal tunnel. That's common during pregnancy. And then increased blood volume and physiologic anemia. So, like we said, our blood volume as a whole is increased by like 40 to 50%. All of these changes that are occurring is to prepare mom for delivery and for labor, okay? So we're giving mom all of this extra blood to prepare for the amount of blood that she will lose during labor and during delivery, okay? So the human body is pretty amazing in that aspect, that it is preparing mom for her anticipated amount of blood loss after delivery the minute that she becomes pregnant. Okay. Physiologic anemia is because, right, we have that increased amount of red blood cells. We have the same amount of other plasma product, which can lead to some physiologic anemia. All right. So moving on to content for this week, we're going to talk first about our stages of labor. Okay. So what is the first stage of labor?
Contractions?
The start, yeah, when it starts with contractions, your first stage of labor. When is your first stage of labor over?
Isn't it when you are like dilating, like about to have the baby?
Yeah, it's whenever mom has had complete cervical dilation and 100% cervical effacement. Yep. So, your first stage of labor is the onset of labor to complete full dilation and effacement of the cervix. Remember, with this stage, this is the only stage that is divided into two phases, okay? So, you have your latent and your active phases. So, what is your latent phase? Think about it in terms of cervical dilation. That makes it a little easier to remember.
It's like the first, like when you're just barely getting dilated.
Yes, so yeah, that starts when you're first barely like dilated and you're starting your labor. When does the latent phase end and when does the active phase start? When you're how many centimeters usually?
8 centimeters.
It's a little earlier than that. It's 6 centimeters.
Oh,
Mm-hmm. So our transition phase, which is the active phase, they kind of keep going back and forth on what they want to call it, is whenever we're 6 centimeters until we're fully completely dilated. Okay. So, but those two phases fall under the first stage of labor. What is our second stage?
Delivery of the infant.
Yeah, delivery of our baby. So it starts with that complete dilation and effacement of the cervix to the delivery of the baby. This is the stage that mom is usually pushing, okay? I don't want you guys to get confused though, because can mom feel like she needs to push during the first stage of labor in that active phase? Yes. Moms sometimes will get the urge to push when they're like 8 centimeters dilated, depending on how low that baby is. So if mom starts to have that Ferguson reflex or that reflex that she has to bear down, that can happen during the active phase of the first stage of labor. Okay. But we don't let mom start pushing until that cervix is completely gone. Otherwise, she's at the risk of having a cervical tear or laceration. So we don't usually actually let her push until the second stage of labor when she's completely dilated. That's the difference. You can still have that urge in the first stage, but you don't actually start having mom push until the second stage. Okay? What's our third stage of labor?
From the birth of the baby until they deliver the placenta.
So this is the delivery of the placenta. Yep, you got it. So second stage ends with the delivery of the baby. Third stage begins with the delivery of the baby and then the delivery of the placenta. So pretty much your third stage, I want you guys to remember, is just delivery of that placenta. Typically, placentas come after the baby, usually within like 5 to 20 minutes. It's not very long. The third stage is pretty short typically. If it lasts a long time, there's probably something going on with the placenta that's causing it to stay in the uterus, and we're probably going to have to do some more intervention as far as medication goes. What is our fourth stage? Last stage.
Is it recovery? Like
Recovery.
mom recovery?
Yep. The first 2 hours after delivery. So, if you look at it, your first stage of labor is going to take up a lot of this time. Okay, it's basically her entire labor is the first stage. Usually, the second stage of labor, whenever mom is actually pushing, lasts no longer than like 3 to 4 hours. The longest I've ever pushed with a mom was 4 hours, and that was a long time for that mom. So, usually, providers don't let them push for that long. The third stage is usually the quickest, and then your fourth stage is that 2 hour recovery period. Okay. What are the 5 P's that affect labor and birth?
Passage, passageway, power. I don't know the other two.
You're so close. You got some of them, yeah. So we got passageway, we got power,
passenger,
passenger,
position,
position. Yep. One more.
psyche,
Yeah. Psyche. So we got passenger, passageway, powers, position, and psyche. You guys should know that. There might be some questions about the 5 P's for sure. Okay. All right, so when we're breaking it down, we have to look at these each individually because each of them are going to affect our labor process, okay? Our passageway. Obviously, whenever we're talking about having a delivery, we need to know the anatomy and the fit of mom's pelvis, the shape of her birth canal, her cervix, her pelvic floor, soft muscles, all of the things that are making up the mechanism that is going to be delivering and helping pass that baby, okay? Um, Passenger refers to the baby itself, right? The baby is the passenger in the entire birth and delivery process. So this is we're talking about the fetus, where the placenta is, fetal lie, attitude, position, presenting part. All of those big terms that that I talked about in my recorded lecture. You guys will definitely need to know those. Powers. When we're talking about powers, we're talking about primary and secondary. So our primary patterns are going to be our uterine contractions, okay? The powers that are primary are the powers that our mom's body is going to do naturally on its own, okay? Secondary would be maternal efforts or anything that we do to increase what our body is already doing, okay? So just think about it divided into like primary powers are things that your body does on its own naturally, whereas secondary powers is going to be mom's efforts or anything that we add to increase contractions. Okay? Position, changing positions. We're going to go through in this PowerPoint and talk about what positions are ideal for labor versus ideal, which are not. And there are different positions that can help with different things. So we'll need to know that as well. Psychological. This is a huge component to any labor and delivery process. Some will even say that this is the most important component whenever we're talking about a successful delivery. So we need to monitor our patient's response and emotions. What kind of previous experiences has she had? Has she had a traumatic delivery? That's going to affect how she's coming in for this delivery. What is her preparation? What's her birth plan? What does she want for this delivery and her labor? Taking into consideration her culture, or what kind of cultural impact and how much cultural impact does this patient want in her delivery and in her birthing process? Okay. What does her support system look like? Is this a adolescent pregnancy who's coming in who doesn't have very much support at all and you're going to be their primary support person? Is this somebody who comes in whose support person fell asleep in the corner chair at 3 a.m. and you're their support person now because everyone's getting tired? You know, whatever it may be, we need to respect what this patient wants, right? All right. So starting off here with factors affecting labor are passenger, okay? So this is going to come into all that terminology that I mentioned, that fetal presentation, the lie attitude position, and the ability to adapt to the birth canal. So what is our best position for the baby to be in to deliver vaginally? Besides cephalic, right? We want that baby's head down. But what would we call it? If we're going through all the like cardinal movements, the presentation, lie, attitude, position, what would we call it?
Is it longitudinal? No.
No, it is you're kind of on the right track with the terminology. I see where you're going. So this is occiput anterior. Okay, so occiput is going to be referring to presentation. What part of that baby is coming down first, right? So that is the back of this baby's head. This is the top of the head where that soft spot is, and that's where we want baby. Anterior is in relation to mom. Okay, so let me pull up this picture here. So which of these babies is in an occiput anterior position?
The first one.
That first baby. Yep. And we know that because that baby's spine in relation to the mom's spine and the way that the baby's head is facing, the way the baby's face is facing. Okay. So baby one here on the left would be an occiput anterior position. Does anyone know what this one would be called?
I guess posterior.
You got it. It's kind of a trick question, but not really. Yeah. Occiput posterior.
Oh, I was joking, but okay.
You got it. That was right. Yeah. So this is what we would call an OP baby. So, like, if you even just look at the way that this baby is facing and the way that the vaginal canal and the pelvis is tilted, this head is in a much better position to come down smoothly through the vaginal canal. If you look here in this posterior baby, that head is going to be getting stuck somewhere around here. And that is when moms have excruciating back labor. Their labor gets drawn out. They call this baby when it's born a sunny side up baby. I don't know if any of you have delivered a sunny side up baby, but I'm sure you can attest to the fact that it was probably very painful and a long time. So, occiput anterior is the best position for babies to be in to deliver vaginally. And I want you guys just to remember that for sure. What enables the baby's skull to adapt to the maternal pelvis during the birth process? What anatomy does baby possess that allows them to help pass through?
The soft spot,
What would those be called? Do you remember?
the
Isn't it the sutures and the frontials or
Fontanelles. Yes, you got it. You guys were close.
frontals?
Yes. So our cerebral sutures and the two fontanelles, the anterior and the posterior, during birth, the slight overlapping of cerebral bones can occur, causing molding of the fetus's head. So these sutures and fontanelles, what they basically do is they allow for that baby's skull to kind of shift and move around during delivery and during labor. Okay. So whenever you have a baby that's born and like you see has a giant cone head, right? That would be what we call molding, which is a natural thing that happens during delivery and during birth, and it just allows that baby to fit better through the vaginal canal. Okay. But if we did not have the presence of fontanelles or sutures, that baby is not going to be able to come down through the vagina because it won't fit, right? It needs to be able to move a little bit. One time I did actually have a patient in when I worked down in Amish country that we were running her labor all day and the baby was just like not coming down, failure to descend. We did a C-section and it turns out that baby's fontanelles and the sutures had already fused, which is like super rare. Like does not really ever happen, which so that's why that baby wasn't descending because that baby's head wasn't going to be able to mold to fit mom's body. Okay. All right, passageway. What do we take into consideration whenever we're assessing a passageway for a mom?
The shape of their pelvis.
Yes, that's a big one. Definitely. What else are we assessing a lot during labor, specifically?
Her cervix.
Her cervix. Uh-huh. And then what becomes important when we get to our second stage of labor when we're pushing? What does mom need to use in order to help push that baby out? We have to take into consideration the soft tissues of the pelvic floor. So our pelvis, we're going to talk next about what is our ideal pelvic shape for delivery. Do you guys remember what that is? Which one?
Gynecoid?
Yeah, gynecoid. Exactly. So we need to know what the mom's pelvis shape is because there are some that are not compatible, excuse me, for vaginal deliveries. Okay. For our cervix, that is what we're going to be assessing whenever mom's in labor to determine what she's dilated to, how much she's effaced, if the cervix is nice and soft. That's kind of a big factor in labor. The soft tissues of the pelvic floor. So when we're talking to moms about strengthening their pelvic muscles prior to and after delivery, it's not only so that she doesn't like pee her pants whenever she sneezes or coughs really hard. It's mostly too because those are the muscles that she's going to be activating whenever she's trying to push that baby and expel that baby during delivery. Okay. So whenever I'm assisting with births, because most of the time you're pushing with the patient at the bedside, the providers aren't. Sometimes, if mom is okay with it and you've gotten her consent and she's fine, if you put two fingers down at the base of her vagina and you tell her, push my fingers out, that helps her to activate the soft tissues of her vagina and that helps her to push more effectively and to bring that baby down and help that baby descend. So, we already talked about what is the most common and conducive to vaginal births. Do you guys remember which one increases the risk of having C-section? Or you definitely will probably have to have a C-section with this type of pelvis shape.
Is it like the retro or the in
It would be the platyploid, I think is the name for it. Let me look. Yep. So here has all of them listed for you. Your gynecoid is the one that's the most common. It's the round shape and it's conducive to a vaginal birth. Your anthropoid is less common and it's oval shape that makes descent into the pelvis a little bit slower, but still most women can have favorable or can have vaginal birth successfully. Your android, which I always think of the phone whenever I see this word. So I wish someone had picked something different, but that's okay. Um, 23% of women have this, and it's the heart-shaped one, and it's common for a male pelvis. Your potential for C-section is higher with this because the fetus is going to engage in a transverse or a posterior position. So that's going to make delivery hard. Your platyploid is very, very rare. It's that flat and oval shape, and that's going to require a C-section. Okay, so then I have pictures of them over here. But for the purpose of your exam and for studying, I want you guys to know which one is the most common and favorable for a vaginal birth, which is your gynecoid, and that your platyploid is the one that most likely will end in a cesarean birth. Okay. What is it called when the fetus drops or engages into the pelvis? What's the terminology for that? This is what we would refer to as lightening. Okay. So definitely know the terms of like OB stuff because there's a lot of different little terminology that we throw at you. Okay, so lightening is what we call it when the baby drops or engages into the pelvis. When measuring labor progress, a woman may be reported to be 3 centimeters, 40%, and -1. What does that mean? And what does that have to do with the passageway?
Isn't it referring to dilation and effaced?
Yep, yep. So which one would be for your dilation?
The centimeters.
Yep, and then your effacement would be your percentage. And
I
then,
don't, I don't really understand, like when they say effacement, like visually, what does that mean?
so effacement is hard to kind of visualize because most of the time you're like feeling it with via like a vaginal exam. So whenever you get a non pregnant cervix, the cervix is typically really long and it's super thick. Okay, and that's a defense mechanism so that nothing can really like go up there and it reduces our risk of infection. Okay. During labor, effacement is referring to that thinning of the cervix. So it gets shorter, it gets thinner. That's what that means. Our dilation is when it starts to get wider and it starts to open up to allow for a baby to come down into the vaginal canal. Okay. So our effacement is kind of hard to visualize it, but it's usually whenever the cervix starts really, really long and thick, and then your effacement begins when it starts to just thin out and get shorter. Okay. 100% effaced, you barely can even feel that cervix. Like it almost feels like it's not even there. It's just really thin. It feels like, I don't know, the width of paper, really. Um, and then your dilation goes from closed. So, like some people say it feels like the nub of an eraser to fully complete, which if you're complete, your fingers are like this, feeling all the way around the baby's head. Okay. So in this instance, the cervix is 3 centimeters dilated and 40% effaced, and the presenting part is 1 centimeter above the ischial spines. So that -1 is what we refer to as our station, which is just indicating where baby's head is in relation to the ischial spines and the vaginal opening. How close is baby to being delivered? Okay. So for this, I want to run through it with the video. So dilation, effacement, cardinal movements, and mechanism of labor. Okay. These things are all affected by the shape of the pelvis and the fetal position passenger. So I'm going to bring them all up here and we're going to go through it when it's happening in the video. Okay. Because I think it's easier to visualize these things rather than try to explain them all to you. Okay. So our first thing that needs to happen, obviously, is we need our baby's head to engage. So here's our baby coming down. It's engaging. It enters into that pelvic outlet. It's putting pressure on the cervix. Now we're having descent. It's descending down through this vaginal canal. As it descends, that baby's going to flex. So it's going to curl in around itself, tuck its chin to its chest, and you see it internally rotate so that its head adjusts to the pelvis. The head will then extend to come down through the vaginal canal. We have that last external rotation, and then baby is born. So those are the cardinal movements of labor. So again, we have our engagement here. Baby's head is coming down in the pelvis. We have descent down through the vaginal canal. As baby is descending, we see baby's head tucked down to the chest. It gets really compact. We're flexing in. We see internal rotation here to help fit through the vaginal canal and the pelvic inlet. The head extends to come through that cervical opening, that vaginal opening. We see a last external rotation, and then the baby is born. I think it's a little bit easier to understand that as we're watching it with the video rather than just like, okay, here's what happens here. And then, yeah. Your textbook goes into like the actual medical like terminology definitions for each of these phases, but I think it's really helpful to see it like this. Does anyone have questions over that? Okay. All right. So now let's go down through a list, and I want you guys to tell me if these factors that are affecting labor, these powers, if they're primary or secondary. So the Valsalva maneuver. First of all, what is that? Does anyone know what the Valsalva's maneuver is?
Google says that's when you close your mouth and forcefully exhale.
So this is the like fancy word for mom pushing. Yeah, it's the act of mom pushing. So if mom is pushing, is that our secondary or our primary power?
Secondary.
Secondary, yep. If we have involuntary contractions during labor,
Primary.
primary. If we are adding force to uterine contractions to augment the forces of involuntary contractions, what would that be?
Primary?
So this one's tricky. This is secondary. Because here, keyword is that we're adding force. So if anything is being added outside of what the body is naturally doing, that is your secondary power. The voluntary pushing efforts of the laboring mom,
Secondary.
secondary. The feeling of wanting to bear down,
Primary.
primary. Yep. And then the process of shortening or thinning of the cervix during labor, also called effacement,
Primary.
primary. Yep. And then the process of dilation of the cervix until it is fully dilated.
Primary.
Yep, primary. So anything that is happening naturally in the body is going to be your primary reflex. Anything that is being added would be your secondary. So whether that's mom pushing, that's us giving the mom medication to make her contractions stronger, um, that would be secondary power. All right. Factors affecting labor power. Okay, so whenever we're talking about that, we're also going to be starting to talk about our fetal heart rate tracing and our contractions. Okay, so I'm not sure if any of you have ever read a fetal heart rate monitor or have looked at strips before, but we're going to go through those here now. Okay, so breaking it down, here is your fetal heart rate tracing. This top part here is where you're going to find your fetal heart rate. This bottom part here is our contractions, where we would read our contractions. So we're measuring our contractions by noting what the frequency, duration, and strength of the contractions are. How would we measure the frequency of a contraction?
From peak to peak.
So you can do it that way. We teach it that you teach it from this, you measure it from the start of one to the start of the next. I don't want to say you're wrong because realistically, if you're measuring from the same point of one contraction to that same point on the next contraction, you can still get an accurate frequency. But for the purpose of the class, we teach that you should measure from the start of one contraction to the start of the next. How do you measure your duration?
Don't you count the segments, like the amount of boxes in between?
So you count, yes, the amount of boxes just during one contraction. So the start of one contraction to the end of that same contraction is going to give you the duration or how long that contraction is. How do we measure the strength?
The height of the peak?
So that's what a lot of people think. So the only time that you can actually measure it using this is if you have an intrauterine pressure catheter or an internal monitor. Otherwise, these numbers don't really mean anything in correlation to the contraction unless you have that internal monitor. Okay. So the strength of the contraction is the only thing that we measure via palpation. So we're feeling mom's belly. So we measure it in mild, moderate, or strong. A mild contraction feels like if you were to poke the tip of your nose. It's kind of soft. You can still feel some firmness under there, but it's pretty like you can move it around. It just would feel probably how mom's belly feels when it's normally resting. A mild contraction is if you're feeling your chin a little bit firmer. It's still some kind of soft. We're not too worried about that. That's a good contraction, but it's not going to be super strong. And then strong would be if you're feeling your forehead. That is how strong we want and how hard we want that mom's belly to be in order to have successful contractions that are going to cause change. Okay. So when we look at this tracing here, important things to note. So from red line to red line would be considered 1 minute. So these little boxes in between here are each going to be 10 seconds. And then, so that's how you would read that. These numbers, like I said over here with your contraction monitors, they don't necessarily mean anything unless you have an IUPC. Otherwise, we're just monitoring our strength via palpation. Up here, we're going to talk about these numbers because we do use these numbers whenever we're reading and whenever we're reading the fetal heart rate. Okay. So, Ms. Chang is in labor with her first baby. Her contraction started at 8:12 and ends at 8:13. So, how long is that contraction? About just rough guesstimate range.
A minute.
Yeah. The next contraction starts at 8:15 and ends at 8:16. The fundus is difficult to indent with fingertips during the contraction and soft between contractions. So, what is the space between the contractions? If the last one started at 8:12, the next one started at 8:15.
3 minutes apart.
And then we're saying that fundus is difficult to indent with our fingertips. So, what would we say that strength would be?
Strong.
I'd say, yeah, moderate probably to strong. So we are 3 minutes apart, about 70 seconds, a minute to 70 seconds, and it palpates moderate. So that's how you guys would read that, and that's the terminology that's associated with contractions. What is our desired frequency and duration? What do we want to see for a successful labor? How far apart do we want our contractions usually?
Is it 2 minutes?
2 to 5 minutes. Uh-huh. And then what do we want our duration? How long? I'll give this one to you. So we want them to be about 2 to 5 minutes apart, and we want them to last about 50 to 90 seconds. Okay? This is a sign of a good contraction or a good contraction pattern. What is the definition of having too many contractions? A tachysystole or contractions that are too long? So it would be having more than 5 contractions in 10 minutes that last longer than 90 seconds. So if we have a tachysystolic pattern, okay, you're having contractions every minute. Who are we worried about? Are we worried about the mom? Are we worried about baby? Are we worried about both of them?
Both.
Both, but more baby.
Yes, I would say I would agree both, but mostly we're going to worry too about baby. But yes, both of them we're going to worry about. So let's think about it from an anatomy standpoint. Your uterus, so during a contraction, it is squeezing, right? It's a muscle. It's basically that's what the contraction is. It's a muscle that's contracting. It's putting a lot of pressure on your baby. It's reducing the amount of oxygenation to baby briefly because of that constriction and because it's of that limited blood flow. Typically, babies have enough oxygen stores or reserves that during labor, they're fine. The contractions don't typically um, do anything or affect them. If you have a period of time where you have like an hour where there's contractions every single minute, do you think that baby is going to be able to sustain that? No. Because, like, think about it. It's contracting down, it's reducing that amount of oxygenation to baby. Baby is getting limited amounts of oxygen. They're burning through their reserves. And that baby is going to start to show you signs that they are not tolerating this labor. Okay. During this breast period between contractions, that is when we see an increased amount of blood flow to the baby. We're seeing a recovery period for the placenta. Baby needs that recovery period and be able to withstand more contractions. If you're having a contraction every single minute, boom, 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 right after one another, that baby's not having enough time to recover, and that oxygen supply is going to be diminished to the baby. It can lead to fetal hypoxia. Okay. From a maternal standpoint, think about it like a muscle again. The uterus is a muscle. If you go to the gym and you do 1,000 pull ups, okay, your arms are going to get pretty tired very quickly into that if you're doing them repeatedly, one after another, one after another, one after another, right? So the same thing happens with repeated uterine contractions. That mom's uterus is going to get really tired and it's either going to stop and completely poop out on you, or it's going to just have ineffective contraction pattern, which can lead us to a C-section, right? So the biggest risk for mom with tachysystole of the contractions is a uterine rupture. Okay. So that is why we have to monitor mom and baby and the contraction patterns so closely during labor because we don't want them to get too close together because it can pose problems for both mom and for the baby. And then we talked about quantifying the strength of contractions. Quantifying, though, if we actually want to have a numerical value, we need to have in an IUPC, an intrauterine pressure catheter. Okay, before we start talking about fetal heart rate baseline, I need to go to the bathroom. So if you guys want to take 5 minutes to go pee, I'll be right back, okay? All right, guys. Thank you so much. If you guys want to come back on screen, we'll get finished with the class. Awesome. Okay, so we just went over uterine contractions. Okay, so that's half of our fetal heart rate monitoring. The other half that we have to discuss now is how do we monitor and how do we read our fetal heart rate baseline or our fetal heart rate. Okay, so like we said in the last slide, this bottom section here of the fetal heart rate monitoring is your contraction pattern. That's where we're going to read and view and interpret our contractions. This top part is our baseline, our fetal heart rate. Okay, so this is what we're going to look at whenever we want to know what our baby is doing. What is our normal baseline? It's kind of written up here for you already. So it's 110 to 160 beats per minute. That's a normal fetal heart rate, whether the baby is in utero, the baby's delivered, whatever it may be. So it doesn't really change. We want that heart rate to be between 110 and 160 beats per minute. What are we talking about when we are asking what is baby's variability of the baby's baseline? What does variability mean? Or how do we assess it?
A change in fetal heart rate within about 15 beats.
Yeah. So my last class, I used a very medical term. I said it's basically how squiggly your line is. Don't go by that for the exam. The word squiggly will not be on your exam, but that is the best way for me to kind of talk to you about it right now. So let's look at this example here. So the numbers on the side here are going to be what our fetal heart rate is. So you're looking at this, and the heart rate looks like it settles around here, this line. So I would say the heart rate baseline is 145. That's whatever that heart rate is coming back to after having these really big accelerations. Variability is just the deviation on this line, okay? So what are the categories for fetal heart rate variability? Do you guys remember? There's 4 of them.
Do you mean like acceleration, deceleration?
So not exactly. So with variability, we are looking at these 4 categories: absent, minimal, moderate, or marked. Okay. So absent variability would be this line up here is completely flat. It does not change off of that fetal heart rate baseline at all. So say our baseline is 145 on this strip. That heart rate would stay within 145 basically this entire time. And this is an 8-minute strip, so that is kind of a lot of time for a baby not to have any variability, right? Minimal means that this heart rate is excelling up by less than 5 beats. Okay. And then moderate would be what we want it to be. That's our normal, which is when it excels off of the fetal heart rate baseline by about 5 to 25 beats. Marked it looks kind of crazy. Like the way that it looks is almost like VTAC, but it's not VTAC, obviously. It's a fetal heart rate. It would be where the baby's heart rate is going up and down and up and down. And it's almost hard to determine what our baseline is with marked variability because it's that greater than 25 beats increase. Okay. So when we talk about variability, we're talking about the deviation off of baby's baseline. Okay. Does that make sense to everybody? Awesome. Here, this little arrow, this pink arrow, is pointing at an acceleration. So the best variability is our moderate variability. That's what we want. Define accelerations. Do you guys know what our acceleration parameters should be? I know your textbook gives you like a numeric window for accels. It is an increase from baseline at least 15 beats and lasting for at least 15 seconds. Okay, so when we talk about 15 beats, that means up, okay, going up 15 beats. Seconds obviously is over because, like we said, each of these boxes is 10 seconds. So this acceleration is definitely more than a 15 by 15 acceleration, but we don't see that reoccurringly through here, so we're not going to call this marked variability. We just have an acceleration, and that's a good accel. Accelerations mean that your baby is doing well. Okay, so accelerations are good. We want to see those. Those are the best indicator that your baby is being well oxygenated and that your baby has a reassuring heart rate. Does anyone have questions on that? This is like your base knowledge for fetal heart rate monitoring, so I want you guys to feel comfortable with it. Okay, we'll move along. So whenever we talk about accelerations and fetal heart rate baseline, we have to also talk about decelerations and what can happen if we have a abnormal event or something that we don't want during fetal heart rate tracing, okay? So there are three major decelerations that we're going to talk about. I talk about another one in the recording, so please watch that because you will need to know that one as well. The mnemonic to help us remember what the decelerations are, what causes the deceleration, and what our interventions are for the deceleration is called Veal Chop 9. Okay, so we're going to go through this together. Okay, so you have that picture in the top of your screen with those decelerations that kind of look like a V shape. Those are what we would call variables. Variables are easy to remember because, like I said, they look kind of like a V. Variables are that abrupt decrease in the fetal heart rate and then a really abrupt recovery. Okay, so they go down and they come right back up. They don't stay down. If it stays down, that's a different kind of deceleration. If it goes down and comes right back up, it looks like a V. That is a variable. Variables can occur with a contraction, but they can also occur without a contraction. So, what causes a variable? Cord compression. That's the second part of this box. So, cord compression can occur with a contraction or without a contraction. So a common cause of cord compression would be with a contraction because that uterus is clamping down and putting a lot of pressure on the umbilical cord. It's reducing oxygenation to our fetus, which ultimately is going to cause a decrease in that fetal heart rate. Okay, so that's why you see that big drop and then recovery. Another thing that can impact and put compression on an umbilical cord would be mom's position and if baby is putting pressure on its own umbilical cord. Okay, so what is our intervention? That's this mine section. Our intervention for variable decelerations is to move our mom. We need to reposition this mom because if we reposition her, there's a good chance that we're going to get that pressure off of the umbilical cord and then our baby is going to become oxygenated again and recover. Okay, so if you see a variable, you need to move your mom. Early decelerations, that is the second picture here. Early decelerations go down and recover at the exact same time that a contraction occurs. So they mirror each other. I want you guys to remember early decelerations mirror the contraction. So in this picture here, you see this contraction starts. As this contraction is starting, we start to see a decrease in our fetal heart rate. As this contraction is ending, we see this heart rate recover and return back to the baseline, which the baseline in this is 150. Then we go for a couple of minutes. We start to have another contraction. Oh, we have another deceleration. We have another early deceleration because it's happening at the exact same time. And then the contraction's over, fetal heart rate recovers back to baseline. What causes a early deceleration? Head compression. This is something we're not necessarily worried about, okay? A baby's head is meant to be squeezed during labor. So this is fine. A head compression is not going to reduce oxygen. It's not going to cause baby to become in a hypoxic state and require emergency delivery. This is not something that we're going to be concerned about. So we do not need to intervene with these decelerations. These are fine as long as they're happening at the exact same time as a contraction. Okay. We already talked about accels. Those are those increases, but 15 by 15. They're okay. It means the baby's well oxygenated. No interventions are necessary. Our last one is the worst decel that we can have. We don't want it. It's a late deceleration. The way I think about it is the fetal heart rate is running late because it happens after the contraction. So your heart rate is late. So here we have the contraction. It starts here. We have the peak of the contraction starting to go away, and then, oh, that heart rate drops. And then it recovers. Same thing. We have the contraction. Oh, here it goes. It's starting to go away. Oh, the heart rate drops after the contraction has started. Late decelerations are your number one concern because it means that your placenta is being insufficiently supplied. Placental insufficiency. So that baby is not being very well oxygenated. Okay. What are things that can cause placental insufficiency? There is a whole bunch of things, like we talked about earlier, maternal hypertension. Sometimes, if mom is severely postdates, that can cause your placenta to start to deteriorate, resulting in placental insufficiency. The ones for our process of like knowing decelerations would be like, what is mom's position? And is she supine? Is she laying on her back? Because that can cause some supine hypotension, right? If mom had an epidural and her blood pressure all of a sudden hits the tubes and she's symptomatic, that baby is going to be showing you signs of having some placental insufficiency, some oxygenation issues as well. Okay. So with late decelerations, obviously these are an emergency. So obviously we're going to be doing some interventions to try and correct these. To remember these kind of interventions, the mnemonic we use is this is the point. So P would be position change. So for moms, what position do we want them to be in to increase our blood flow into our placenta, to increase placental supply?
On the left side.
Yep.
Side.
Yeah, we want her laying on her left side. If we're also noticing these reoccurring, we can put her in hands and knees position. That will also relieve pressure on the baby. That will also help with placental supply. But yes, left side is usually what we want to go to help increase blood flow to the placenta. Oxygen. For labor and delivery, what we typically do is we administer 10 liters via non-rebreather mask to mom to increase blood flow to the placenta, to increase oxygenation to baby. We're going to give her some fluid, give her a bolus. We want to maintain mom's blood pressure, make sure that her vital signs remain stable, that she's hemodynamically stable. Because if mom is hemodynamically stable, then baby is usually hemodynamically stable as well. Okay, so give her IV fluid in order to support her blood pressure. This is also prevalent for moms who've gotten epidurals, right? Because epidurals, like I said, they have a chance, they run the risk. The biggest risk with an epidural is mom's blood pressure tanking. So if mom's blood pressure is dropping, we want to get that blood pressure up because usually baby is going to be feeling the effects of that as well. So giving her fluid, laying her head back, elevating her feet, turning her on her side, all of those things we need to do if mom's having a hypotensive episode. Notify your doc. Because if baby doesn't recover from these, we may need to do a C-section because the baby's at a risk of developing hypoxia or metabolic acidosis. Our tocolytics. So if you're administering tocolytics, what would an example of a tocolytic be? A medication that we give in labor to help give mom more contractions.
Pitocin.
Pitocin, yeah, oxytocin. If you're giving mom an oxytocin infusion and you start to see mom have these late decelerations, do we want to keep giving her that medication? No, because most of the time these decels are being worsened by the cutoff of oxygen from these contractions. So if you're doing any of these other interventions, you best believe that your oxytocin should be turned off. That's usually the first thing that you do. Okay. So for your exam, remember veal chop mine. That's an important thing, especially like whenever we ask you like, if this contraction mirrors, if this deceleration mirrors a contraction, what kind of deceleration would this be? Oh, that's an early. I remember that, you know? So definitely know this graph for your test, okay? All right. Any questions about fatigue, D cells, fetal heart rate monitoring before we move on? You guys still with me? I know this is a lot of stuff. We're doing great. Okay. So the position of mom has the potential to facilitate or hinder descent of the fetus in the birth canal. Regular position changes during labor can relieve maternal fatigue, increase comfort, and improve circulations. Which position might we consider? And what effect could these positions have? So, what are some positions that we can put mom in? What is it? Okay, so let's start with on TV. What are all the moms that give birth on TV usually in? They're usually on their back with their feet in the saddles, in the stirrups. What is that usually called? What's that called?
Lithotomy.
Lithotomy. Yep, exactly. So lithotomy position is that is what a lot of women will deliver in. This is a position that a lot of moms, especially who have an epidural, will push in sometimes. It's not bad, okay? But there are other positions that we can do depending on what's happening with our baby, depending what our labor is looking like, that can facilitate an easier and a quicker delivery, okay? One of these would be called hands and knees. Have you guys heard of this position during labor? Basically, mom's knees are on the bed and her upper body is kind of draped over the back of the bed so that she's more in like a kind of a hands and knees position. It also can just be her being in almost like a tabletop position on the bed, depending on whatever's comfortable and more feasible for mom. This position is awesome because it relieves backache due to back labor, which is caused whenever baby's in that OP position, like that position we talked about earlier whenever we talked about occiput anterior. If baby is occiput posterior, we want mom to be in hands and knees because that's going to relieve a lot of the pressure off of her tailbone and off of her lower back. It facilitates fetal internal rotation by increasing her coccyx motility. So you're basically putting mom in a better way to help maneuver that baby down through the pelvis and through the birth canal. Another really great one is the side lying lateral recumbent position. Okay. So this enhances placental perfusion, right? So because we're not putting pressure on mom's vena cava, causing supine hypotension. It takes pressure off of her perineum, so she's not feeling as much pressure in between contractions. It also is going to facilitate fetal internal rotation, and it's going to promote comfort. Moms are a lot more comfortable in a side lying position. Most of the time, if I'm helping a mom push in the side lying position, it's because that baby was not tolerating lithotomy because that mom was laying on her back and it was putting pressure on her vena cava and resulting in supine hypotension. So if you're a baby, you're pushing with mom, especially if it's a first time mom and we've been pushing for 3 hours, and that baby's starting to poop out, that baby's starting to show signs of hypoxia, we need to turn her onto her side or into a position where she can more comfortably push while also getting that placenta perfused and getting oxygen to our baby. Okay. Semi-Fowlers can be a position that we have mom laboring in. It's more convenient for external fetal monitoring. So if you have a mom who's very difficult to monitor, this is a really good position for her to be in. It also has the effect of gravity too, because mom is sitting up, so that baby's head is pushing down onto the pelvis with some help from gravity. An upright position, same thing. We're looking at more help from our gravity here. And that's going to promote fetal descent. And this also increases impulse from the cervix to the pituitary gland, making primary powers more effective and efficient. If you guys get this question right, I'm going to give you a gold star. We see the word pituitary gland. What hormone is released by the pituitary gland that could be important when we're talking about labor? It's also important whenever we start to talk about breastfeeding.
Is it
Yeah,
oxytocin?
yeah, you got it. Awesome, Macy. Yeah, oxytocin. So your pituitary gland is what's going to be releasing your oxytocin. So having them in that upright position is going to increase the impulse from the cervix to the pituitary gland, releasing oxytocin, which is going to make our primary powers, aka our uterine contractions, more efficient and effective. It's pretty crazy how that works, huh? What factors could affect a mom's or a woman's laboring position? What are some things we have to take into consideration whenever we're positioning our moms during labor?
I guess culture.
Yes.
Medical conditions.
Yes. So does she have any underlying medical conditions that could impact whether or not we can put her in certain positions? Great. That's great. So here are the big ones. So pain, a mom's pain level. If she's in excruciating pain in one position, we do not need to force her to stay in that position. Okay. If anything, we should probably try and help her be a little bit more comfortable, especially if she's trying to deliver naturally. Um, the one thing I will say though is oftentimes if a mom is experiencing more pain in one position, it's because that baby is pushing down harder on her cervix, and that's what's making her labor more painful. And that's probably what the position that she needs to be in to make quicker cervical change. But if she's not tolerating it, we're not going to keep her in that position, right? Fetal monitor placement. So, your number one priority as a laboring nurse is to make sure that you're able to still effectively monitor your baby throughout labor, right? If you cannot see your baby's heart rate or you can't see your contraction pattern, that would be unsafe. So we need to make sure that we are monitoring baby and able to get a good tracing the entire time. So if mom is not able to be monitored well in a hands and knees position, then we need to help move her into a different position that's still comfortable where we can effectively monitor baby. If mom is tired, she may not be able to stand up on her own. So having her labor by standing at the bedside is not going to be an option for her, right? Or same with if she's really tired and her knees are super weak, her legs are super weak, hands and knees might not be an option for her at that point either. So we need to start incorporating our sideline recumbent positions or even our semi-Fowlers or sitting. What's her comfort level? We want to prioritize comfort as we can. And then fetal tolerance, is baby tolerating that position well or not? Okay. Sometimes babies, like I said, they don't tolerate lithotomy position very well, so they need to be moved out of that position because ultimately we're worried about the safety of mom, we're worried about the safety of the baby. All right, select all that apply. Which positions allow for gravity to aid in the fetal descent during labor?
Lithotomy?
If we're talking about gravity, so gravity's on our side, we're wanting gravity to help us.
B and E.
And I guess sitting.
Yeah, so we're looking at kneeling, sitting, and standing. Those are all positions where mom is relatively upright, which is allowing gravity to help descend that baby. Lithotomy, when she's laying on her back and in the stirrups, is not necessarily, unless we put the head of her bed up, but typically we won't be using, she won't be in a position where gravity is assisting us. And then side lying, while it is comfortable, gravity is not in play in this one. All right. So, the Ferguson reflex is the term to describe which of the following actions during labor.
Would it be B?
The desire to bear down. So Ferguson reflex is that urge to push. The Valsalva maneuver is the act of pushing, but the Ferguson reflex is that desire to bear down. And then we kind of talked about this earlier. What phase of labor is this? See how it says phase.
Again.
So this would be during the active phase. So like I said earlier, with our stages of labor, moms will still sometimes feel that urge to push when they're in the first stage of labor in the active phase. The actual pushing starts in the second stage of labor whenever she's fully complete. Okay. But like I said, what stage could this also be? Our second stage. Okay. Because sometimes moms don't actually have that urge to bear down until they're fully complete. But it can happen in the first stage as well. All right. Factors affecting labor, the psyche. So we need to also always monitor our moms. How is mom coping? Does she have a history of sexual abuse? Because that is going to greatly alter how we assist this mom with labor, if we're performing vaginal exams or not, and what mom's comfort level is. Okay. So we're going to run through some phrases here, and I want you guys to tell me if this would be an appropriate or an inappropriate thing to say to your mom as she's laboring. It's time to open your legs and relax while I examine you. This will not hurt much.
Inappropriate.
Inappropriate.
Inappropriate. I'm going to assess your vaginal area to look for any bleeding. I will just look. It will not involve any touch.
Appropriate.
That is appropriate. That would be okay. Because we're telling our mom what we're doing, we're ensuring her that we're not going to be touching her without any type of consent, and we're just assessing. Who would you like to be present while I examine you to determine how much you have dilated?
Appropriate.
Appropriate. And then I'm going to examine you to determine how much you've dilated. Can I ask everyone to leave the room? It will only take a few minutes.
Appropriate.
This would be inappropriate because we do not want to kick anybody out of the room unless our mom tells us. If mom tells you in secret, like, hey, if you're doing a vaginal exam, I need you to kick everybody out of the room, then yeah, go for it. But until then, if she has a lot of people in the room, we need to just ask her what her preferences are and respect those. Okay. So let's run through some things that mom could be doing and then tell me if you think that this mom is coping or not. She tells you that she's coping.
Not coping.
Coping. So she would be coping. We have to kind of rely on, I know, because sometimes the mom will be like, I'm doing fine. And you're like, are you? But if they tell you they're doing fine, we got to take their word on it for it. She's doing rhythmic breathing.
Coping mechanisms.
Yeah, coping. She's relaxing between her contractions.
Coping.
Coping. Yep. She's panicked during her contractions.
Not coping.
Not coping. She's not able to focus.
Not coping.
Not coping. She's super tense.
Not coping.
Not coping, correct. Controlled moaning, counting, or chanting.
Coping.
Coping, yeah. Emphasis on controlled, right? This is her coping mechanism. She's doing it to get herself through her contractions. She's tearful.
Not coping.
We don't, maybe not. I don't know. If I come into the room and someone's crying, I assume she's not coping, but this also could just be like her way of dealing with her labor. So we need to ask some follow-up questions. Like, I noticed that you're crying. Are you coping, or are you still feeling okay with the labor process? What else can I get for you? Trembling voice.
Not coping.
This would be not coping. Yeah. Rhythmic activity during contractions.
Would it be coping?
Yeah, coping. So rhythmic activity could be like rhythmic breathing. That could be mom rocking back and forth, swaying side to side. Um, Sometimes I've had moms that'll say the same thing over and over and over again, even if it's like, I can't do this, I can't do this during the contraction. Sometimes that is their coping and that is them getting through their contractions. Okay, we just need to communicate really well with them to see how they're doing. She tells you she's not coping.
Not coping.
Yeah, she's not coping. We got to take her word for it, right? We're not going to just be like, no, you're fine. It's all good. Like, we need to listen. She's thrashing around in bed.
Not coping.
Not coping. The other thing too is if she's thrashing around in bed or she's moving around uncontrollably, are we going to be able to effectively monitor our baby? Most likely not. So that's dangerous at that point, right? That's whenever I get my mom voice out and I'm like, all right, listen up. You got to lay still for a second so I can get your baby back on the monitor because it's been 20 minutes since we've had the baby on, since we've been freaking out. That's also the time where we need to talk to the mom realistically about where we're going moving forward with her labor, right? Do we need medication, pharmacological intervention? Do we need to do something different to get her in a position that she can tolerate, right? Because if she's thrashing or she's having panic during the contractions, that's not going to help her in her labor process. She's focused.
Coping.
Coping, yep. How can we as nurses support a woman who is coping effectively with her labor?
Positive reinforcement.
Positive reinforcement. Yep. How can we support a woman who may not be coping as well? They're kind of the same, honestly, just to different degrees. So, as a bedside nurse, we want to just be present, right? Sometimes just being in the room is all the patient is going to want from us. Sometimes that's enough. We might be their support person in this situation, so we need to provide our support. Offering that positive reinforcement, even to women who aren't coping, like even to the moms that are thrashing around in bed, that are screaming, that are hyperventilating, we still need to be there saying, you're doing a great job. Take some slower, deep breaths for me. Just be really communicative and be a really good source for the patient. We also can still provide those non pharmacological pain management interventions, offer them to get into the tub if it's appropriate, use some hydrotherapy. If they brought like an aromatherapy or diffusers, like get that going for them. Make the room comfortable. If there's a lot of people in there that the mom doesn't want, help kick them out. We want mom to be as comfortable as possible and to have the labor that she wants. Okay. Now we're moving on to signs and symptoms of labor. So I want you guys to tell me whether or not you think these things indicate that the mom is in labor or not. She has bloody show. Do we think she's in labor?
No.
That is a maybe. So I would say most of the time, it really can go either way. So bloody show, like we kind of talked about, can be caused by a lot of different things. Did mom have sex that day? That can cause bleeding. Is her cervix changing? Because that can cause bloody show. But bloody show is kind of hard to just definitely say yes, you're in labor or not. So we'd have to probably get some more information. Irregular contractions.
No, not yet.
Correct. Nope. We don't. She's not in labor. We need those contractions to be regular. She lost her mucus plug.
On her way, but not yet.
So yeah, this would be no.
No.
Yeah, your mucus plug, moms can lose that up to like weeks before they actually start going into labor. Typically, when we see a mom lose a mucus plug, it means that labor is not too far around the corner. Um, but it does not mean that she's in labor at that moment. Cervical effacement and dilation.
Yes.
Yes.
Yep. That is like the number one indicator for if she's in labor, if she's making cervical change. Spontaneous rupture of membranes.
No.
Correct. No. So just because a mom's water breaks does not mean that she is in labor. And that was confusing for my earlier class. So we'll put it this way. So your amniotic fluid ruptures, right? Your water breaks, water is leaking. That does not necessarily mean that mom is going to start having contractions and that she's going to make cervical change. Our two best indicators for if we're in labor or not is if mom is making cervical change or if she's having regular strong contractions. Okay. Spontaneous rupture of membranes, typically what's going to happen is we're going to have a baby within 48 hours or so, but it does not mean that she's starting labor on her own. Contraction pain felt above the navel. This would be no. Um, Above the navel, I'm not really sure. I think that was just meant to throw you off, but no. Just because they're feeling a little bit of discomfort doesn't necessarily mean that she's going into labor. The fetus has dropped. Excuse me. So we're experiencing, mom experienced lightning.
Yes.
That one would actually be no. And that's just because a baby can drop down into the pelvis weeks before she actually goes into labor. Lightening is just something that baby has to do in order to engage into that pelvis to be in a good position for delivery. Contractions continue to increase despite comfort measures.
Yes.
Yep. If our contractions are getting more frequent and they're getting stronger, that means that we're in labor. Contractions go away whenever you're walking.
No.
No, correct. Yep. So if if my mom is having irregular contractions or even regular contractions, and then she drinks a big thing of water, she lays on her left side, she gets up and she takes a warm shower, and their contractions go away, then that's not true labor. True labor, those contractions, you are not going to get rid of them even if you tried. It's not going to happen. That baby's going to come. So if it goes away with intervention, then it's not real labor. No significant change in dilation or effacement. This would be no. We're not having any change in our cervix, so mom's not going to be in labor. And then your contractions are increasing in severity and frequency.
Yes.
Yep. Awesome. So is it latent and active labor? So a multigravida who has contractions 10 minutes apart that lasts for 30 seconds and is 3 centimeters dilated. What do you guys think?
Latent.
Latent, yep. She's in her early labor, early stage. A prima gravida who has contractions 3 minutes apart that last for 90 seconds and she's 8 centimeters dilated.
Active labor.
Active.
Active, yep. A prima gravida who has contractions 5 minutes apart that last for 45 seconds and is 2 centimeters dilated.
Latent.
Latent.
Correct. And then a multigravida who's assessed to be 7 centimeters, 100% station plus 1. 100% station is plus 1, and contractions are 2.5 minutes apart, lasting 60 seconds. And they're strong.
Active.
Active.
Yeah. I'd be like, let's get a delivery table because this mom's about to have this baby. All right. Moving on here to non-pharmacologic pain management. What are some things that we can do as far as not medicine, non-pharmacological interventions to help with pain management during labor? We talked about some of these already.
Breathing.
Breathing, helping mom with her breathing techniques. Yep.
Um, I forget what they're called, like scents, different scents,
Yeah.
relaxing.
Aromatherapy. Yep. We kind of mentioned hydrotherapy, getting mom in the tub if she can get in the tub. Let's see. We're going to provide a quiet environment by controlling noise on the monitor, speaking in a quiet voice, keeping the door closed, ensuring privacy. Care for the client in a calm, unhurried approach whenever possible, and create that relaxing environment. Dim those lights, control the temperature, provide relaxing music. Okay. Touch and massage can be an effective way to reduce tension and anxiety, distract the laboring mother, and improve comfort. Think about our gate control theory. Okay. How can a nurse assist with this strategy? As far as like gate control theory goes, how can we assist mom? So we need to know the mom's preference first related to touch, okay? We don't want to ever provide any type of massage or hands-on approach to a patient until we talk to them and ask them what they prefer and if they're comfortable with that, okay? So we need to figure out who she's comfortable with touching her and where she's okay with being touched. Offer a head, foot, back, and shoulder massage, and offer light massage to or effort, I don't even know what that word is, on the abdomen. Okay. So this is basically trying to distract mom from the pain of her contractions by providing her with comfort in other parts of her body that could be hurting as well. Provide counter pressure or steady pressure in the sacral area to reduce lower back pain. So that's putting a lot of pressure on that lower back to reduce the contraction pain that she's experiencing. So that is like our biggest thing with gate control theory. This is what we can do in order to help with that. And you guys will want to know that, okay? How can heat can reduce pain by relieving muscle ischemia and increase blood flow, and cold can reduce muscle spasms. How can we as a nurse assist with this? With heat therapy or with cold therapy?
Maybe like getting a blanket out of the warmer and bringing it in.
Yeah, getting a warm blanket.
Getting her an ice pack.
Yeah, I feel like these are pretty, yeah, self-explanatory. So we can provide a layer of cloth between a woman's skin and the heater cold pack to prevent her from getting any burns or from frostbite or whatever. Alternate cold and hot therapy, and that's really that. Breathing techniques can help to increase relaxation and increase control during contraction. And then as nurses, what are ways that we can help mom with breathing techniques?
Guiding her through the breathing pattern.
Uh-huh, definitely. Breathe together with the laboring woman to facilitate a focus on breathing. Encourage deep cleansing breath at the beginning and end of every contraction. And be familiar with paced breathing techniques and which ones are appropriate at which stages of labor. Okay. The other thing you can do is sometimes you can help moms count. Like, okay, take a deep breath and hold it for 4 seconds. Let that out with this count. Things like that can be effective. Okay. Um, Guided imagery can help to increase relaxation and distract from the pain sensation and perception. What kind of things can we do with guided imagery? I'm just going to run through these because we're running short on time. So we can encourage the patient to imagine themselves in a peaceful place, such as the beach, forest, or meadow. Um, we also can use them in conjunction with focused breathing. And then here, this is what I wanted to spend a lot of time on, a little bit more time on. So epidural for pain management. What is the nurse's responsibility during the placement of and when caring for a woman for epidural anesthesia? What are some things that we need to do for the mom?
educate.
Yeah, we need to educate her, make sure that she wants the epidural, right?
If she's getting an epidural, she would need like a Foley catheter as well, right?
Yes, we typically place that after the epidural's been put in so that they don't feel it when we place the catheter. But yeah, we will need a Foley because we can't get her up to the bathroom. What other things do we need as far as like nursing assessment, like for an epidural?
To make sure it's adequately like working, it's placed right.
Yeah, yeah,
The pain.
monitor it. What was that? Sorry.
Monitor the pain still.
Yeah, we need to ask her about her pain. Ask the bedside nurse. That anesthesiologist is coming in. They're about to do the epidural. What are we going to do? What is our role in that epidural placement?
Some states don't allow anybody in the room for the epidural. So if you're in one of those states, maybe just provide the companionship that their birthing partner would if they were allowed in the room.
Yeah. In Ohio, where the anesthesiologists don't usually let the support person stay in the room with the mom. Yeah. So let's pull these up. So anytime your patient is going to get an epidural, you want to give them a fluid bolus because we want to make sure that they are being well perfused prior to the placement of the epidural to help combat maternal hypotension. Okay. So we need to give them that baseline fluid bolus. That's a big one. We're going to be monitoring vital signs, especially our blood pressure. During an epidural placement, we're typically measuring a mom's blood pressure every 5 minutes at the minimum. Okay. We're monitoring our fetal heart rate because, like we said, maternal hypotension can cause a decrease in placental perfusion, which can cause those late decelerations, placental insufficiency, right? So we need to have baby on the monitor the entire time. We need to monitor the client's status, including the fetuses, and assess the epidural catheter and site on a regular basis. We're making sure that it's not only in the right spot still, that it hasn't been pulled out, that it's not red or swollen or irritated, it's not showing signs of infection, it's not bothering the mom any more than necessary. Monitoring that site. We're monitoring her bladder, so putting in a Foley catheter. But like I said, we're doing that after mom has already been numb from the epidural. We're going to help do frequent position changes, okay? Just because your mom has an epidural does not mean we stop moving her in labor because if we're not moving her, that baby is going to be stagnant. That can cause a longer labor. So we usually move our moms that have epidurals every 30 minutes is kind of the gold standard with that. We also need to make sure that we're maintaining skin integrity. Moving mom and moving the patient is going to help with that, right? That's like how any patient is on med surg or ICU, right? We want to keep them from laying on one position too long. We want to check those pressure points and make sure they're not um, uh, rubbing on anything or hitting up against anything that can cause any tears or breaks. And then monitor for pain. Okay. If mom says that her pain is back, we may need to call the anesthesia provider back into the room so that they can adjust the epidural or bolus her epidural to give her more medication through it. All right, what are signs associated with potential adverse effects of epidural anesthesia? What are some things that mom may tell you that'll be like, uh-oh, red flag, this is not good?
A fever,
Yeah, anytime a mom has a fever, for sure.
dizziness,
Dizziness,
Ringing ears.
yeah. Hypotension, so lightheaded or dizziness would fall under that category. Tinnitus, ringing in the ears, a metallic taste, numbness of the tongue or mouth. If mom is complaining of chest tightness or chest like heaviness, we may need to set her up because that epidural may be going the wrong way, okay, or covering too much. A high or a total spinal, like that's what I'm talking about, like her arms and her chest and everything is numb, basically, which is scary. If mom is having some urinary retention, that can also be an emergency sign because we don't want her bladder to be too distended. We don't want that bladder to risk bladder rupture. So we need to make sure we get a catheter in and make sure that it's putting out that normal 30 mLs per hour minimum. Pruritus, any like type of rash or whatever that may develop after the epidural placement. Limited movement. So mom should still be able to sort of move with an epidural. She's not completely under general anesthetic, so she's still cognitive and cognizant. So she should be able to move a little bit still. A longer second stage of labor would be a potential adverse effect. So sometimes epidurals run the risk of slowing down our labor. So we need to make sure we're doing those position changes and things that can help continue that labor process. Another adverse effect with an epidural would be an increased likelihood of forceps or vacuum delivery because mom may not be able to feel as effectively when she needs to push. And that can cause a longer second stage, that pushing. A post-dural puncture headache, so a spinal headache or a tap. Those are bad. Okay. See what time we're at. We'll go through this and then we'll be done. Which of these are signs that could indicate progression from the first stage to the second stage of labor? The laboring mom says, I feel like I need to have a bowel movement. Would that show that she's going from first or second stage? This would be yes, she's progressing. It's going from the first stage to the second stage. The mom says that she has to pee. Is that a sign that she might be in second stage of labor, ready to push?
No.
Nope. The laboring mom says, I am really hungry and would like to eat something.
No.
No.
The mom becomes restless.
Possibly.
Yes, So if mom's getting visibly way more uncomfortable, she's not able to sit still, she's changing her positions, she's showing a little bit more signs of discomfort, that can be her moving into the second stage of labor. The laboring mom has a burst of energy.
Yes.
So this would be no. Typically towards the second stage of labor, mom is way more tired and fatigued. Burst of energy is usually in like that first stage of labor when we're still pretty early. She starts to vomit. This would be yes. We typically will see moms get kind of nauseous or sick whenever her labor is progressing. And if she's vomiting or she's complaining about nausea, it's usually because that baby is moving down, sometimes rapidly, which can indicate that she's going to be ready to push here. The laboring mom experiences shaking of the extremities. Do we think she might be ready to push if she's having some shaking? Yeah,
Yes.
definitely. All right. So let me stop it here because I promised you guys you would get out 10 minutes early and we're about at that time. So what I want you to do, the rest of that PowerPoint that we haven't gone over, I want you to try and answer those questions to the best of your ability. Towards the end of the week, maybe the end of this weekend, I'll post in the course cafe the answers to the rest of the questions. Okay, that way you guys can have them so that you have the correct information as you're studying for your exams. But try to answer them first by yourselves. Okay. Take a peek at that exam one review schedule. Please try to attend at least one of those this week. I think they'll be really beneficial to you. But as long as you guys don't have any other questions, I think we're good to go today. And if you need anything in the meantime, please don't hesitate to reach out. Okay? Thank you guys so much. You guys did awesome. That was a lot of info, and you are all amazing.
Okay, thank you. Good night.
Thank you. Bye.
Bye. Have a good night.